Hello, I'm Gavin Giovannoni. I'm a neurologist working at the Blizzard Institute, which is part of Queen Mary University of London. And my collaborators on this project is Dr. Ben Bloom, who works in the A&E department at the Royal London Hospital, and Bhavneet Kaur Singh, who is our research coordinator and nurse on the study. What we're trying to do is develop a treatment for mono, and I'll explain the rationale of the study to you in this short video. First of all, what is mono? So mono is actually short for infectious mononucleosis. The other term is glandular fever, and this is the acute infection you get when you have Epstein-Barr virus infection. It typically presents in adolescent or early adulthood with a very sore throat, pharyngitis or tonsillitis, with a very high temperature, very enlarged lymph nodes, profound fatigue. This is often referred to as kissing disease because the virus is transmitted in saliva, and it typically occurs in young adolescents or adolescents and young adults when they start kissing for the first time and exchanging saliva. The acute infection is usually self-limiting and resolves in about 2 to 4 weeks. However, it is associated with complications which I will address shortly. Now, the problem with mono is that it's often not diagnosed simply because when people come in with a very sore throat and you look in the throat, you often see a white membrane, which is actually pus in the back of the throat around the tonsils and the pharynx. And this often mimics what we would call a strep throat. And most clinicians who look at this think about streptococcal infection, a bacterial infection, and they often prescribe antibiotics. And we know the antibiotics will be effective for streptococcal infection, but because the mono is caused by a virus, these antibiotics don't work. And this would be inappropriate prescribing of antibiotics to treat a viral infection. Unfortunately, at present, we do not have a licensed therapy, an antiviral therapy that's been shown to work in infectious mono. And that's the aim of this study. Now, occasionally people with mono get short-term complications. The most common one is the throat infection is so bad that people can't swallow or eat, and so they get dehydrated. Or the swelling gets so big that they have difficulty breathing and they come into hospital and have to be admitted for treatment of dehydration or breathing difficulties. Infectious mono also causes the spleen to get very big, and a small number of people may present with a ruptured spleen, and that can be life-threatening. And then it also triggers some immune responses that may damage the peripheral nerves, and there's this condition called Guillain-Barré syndrome, which usually presents a few weeks after mono, where people become paralyzed from inflammation in the nerves. Occasionally, it affects the hematological system, and people present with bleeding as a result of the platelet, the little cells that cause clotting to drop, or they may present with anemia because of rupture of their red blood cells. Occasionally, it causes inflammation in the liver, hepatitis, and the hepatitis can also be fatal, and rarely people get encephalitis. And there are quite a few other complications as well that may occur from acute Epstein-Barr virus infection. Now, the long-term complications, some people actually develop what we call post-viral fatigue. It's not too dissimilar to long COVID. So weeks to months after the mono is cleared, people are still fatigued. And a small number of these people go on to develop chronic fatigue syndrome. In other words, their fatigue remains for years after the acute mono. Actually, when you go into chronic fatigue syndrome clinics, about 1 in 10 people will say that their chronic fatigue syndrome was triggered by mono. Another thing is mono also affects the immune system, and it puts people at risk later on of developing autoimmune diseases. And the one that we worried about most is multiple sclerosis. It typically occurs on average about 7 to 8 years after mono. And so something happens that triggers the autoimmune complications. And we also know that the virus, EBV, infects B cells, and that may lead to, it's a white blood cell, that may lead to cancers of those white blood cells, and we call them lymphomas. So people with infectious mono not only have risks of the acute infection, but when they get better from the infection, they're at risk of developing long-term complications. So at the moment, there are no current antivirals. So occasionally people have to be admitted to hospital put on a drip, and we often give steroids to try and shrink the lymph nodes to allow them to breathe more easily. The treatment is purely supportive. So all we do is give them bed rest. We make sure they're hydrated either orally or via a drip, intravenous infusion. And we give them over-the-counter analgesics, things like paracetamol and ibuprofen to keep the temperature down and make you feel better. And then we wait for the disease to spontaneously clear itself and recover. Now, mono has a socioeconomic impact. So people who have mono often have to miss school. Actually, they have to miss school. They usually have to take off at least 2 weeks because they're infectious during that period of time. And many people actually miss more than just 2 weeks of school. The same thing happens to university students, and about 1 in 4 university students who gets bad mono, will have to repeat the year. And that's not trivial, having to repeat a year of university studies because and then obviously there's a loss of productivity in terms of work. And also, for example, in the military, if you go into the military and you develop mono as part of your basic training, you can't do any physical training for about 2 to 3 months, depending on which country you live in, because of the risk of splenic rupture. So exercise is considered to be a risk factor for the spleen to rupture. So that also impacts on physical training in the military. So all this has an economic impact. And then also there's the healthcare costs, because a small number of people have to be admitted to hospital. The average time they spend in hospital is 3 to 4 days. And as you know, each day in hospital costs money. And then obviously we have difficulty working this out, but the prolonged fatigue, which prevents people from studying and working, has a major economic impact on that individual. And sometimes they have to lose their jobs or stop working, and obviously they lose income. They're not taxpayers. They have to get benefits, and so the economic costs spiral out of control. And I also want to say that a small number of people who have mono actually die as a complication of the infection. That's usually the hepatitis or the splenic rupture or one of the hematological complications. Although this is rare, there is a significant number of deaths that occur every year in people who have a mono. So we definitely need a effective treatment, obviously, to try and prevent the severe mono from getting worse. Hopefully, an effective treatment will allow people to recover very quickly, and it will also prevent the complications, prevent the splenic rupture, prevent the need for hospitalization because of blocked respiratory function. And also, by treating mono, we may prevent the immune changes that occur as part of infectious mononucleosis, and therefore prevent the long-term complications like the autoimmune diseases such as multiple sclerosis. Now, we rely on our immune systems to fight infections, and this is no different for mono. We have our white blood cells that have to respond to the virus, and there are two main ones. The B cells, these are the cells that produce antibodies. And that's how we can know if you've been infected in the past. You make antibodies against the Epstein-Barr virus. And then the T cells are really critical. These actually expand dramatically during the acute infection, and that's why it's called infectious mononucleosis, because the mononucleosis refers to the expansion of the T cells that are fighting the virus. And something happens to those T cells in a small number of people that triggers the development of autoimmune disease in the future. And so the theory is if we can prevent or can suppress the virus without needing the immune system to attack it with an antiviral, we'll prevent the complications that occur as part of the immune response that occurs during acute infectious mononucleosis. Now, EBV absolutely damages the immune system in fundamental ways. First of all, the virus actually infects B cells, the antibody-producing cells, and it goes into a latent phase in the so-called memory B cell, and every now and again it reactivates and gets spread in the saliva. That's how it keeps itself moving in the population. But I think more importantly, it's the immune response to the active virus, that something's happening during that immune response that triggers a later development of autoimmunity. We have some clues from studies done many, many decades ago, and we have new technology now. We would really like to know, using some new research techniques, what's happening to those T cells when they're fighting the virus that puts people at risk of developing autoimmune disease in the future. And also, the virus can immortalize B cells, in other words, keeps them alive forever. And during the process of immortalization, those B cells may acquire mutations that sets them up for future cancer. And so by treating IM and reducing the viral loads, we may prevent some of the cancers as well. So that's why we would like to develop a therapy for acute infectious mononucleosis. We know that mono is a major risk factor for multiple sclerosis. So people with a history of infectious mono have about a 2.5 times higher risk of getting MS compared to people who don't have mono. Okay, and similarly, we know that a certain number of people will develop various lymphomas as a complication of acute mononucleosis. And so we may be able to reduce the risk of that if we can suppress the virus. And so this is one of the hypotheses or we want to test in the future is can we develop a treatment to make people with mono get better much quicker, prevent the proliferation of the virus that triggers autoimmunity and autoimmune disease. And obviously, if we can make people get better from the infection, we'll prevent hospitalizations, prevent both and prevent the short-term complications and actually improve the socioeconomic, will reduce the socioeconomic impact of acute mono. So this is what we would like to do is we would like to see if we can find out how mono triggers autoimmunity by studying people with acute infectious mononucleosis. So there are 3 parts to our study. The first part is to get people who come to our A&E or to our hospital with a severe sore throat, and they may be diagnosed, or the clinician who's seeing them would say this person may have a streptococcal throat infection or infectious mononucleosis. We will do tests on them, and we'll get the results maybe a day or 2 later, and then we will contact these people to say, you've got streptococcal throat infection or you've got infectious mononucleosis. We'd want you to come back to the hospital so that we can give you treatment or potential treatment. If it's strep, we'll give them antibiotics. If it's mono, we don't have a treatment right now, but we'd ask people to participate in a study looking at what happens to the immune system over time. People have to be consented to be in the study, and then we'd like to collect over a 2-year period, different time points, blood samples to look at the immune function, as well as throat swabs to look at the viral loads. And visits will happen on day 0 when they come back to the hospital for the first visit, day 7 and week 4, month 6, 12, and 24. Now, the reason why there has to be a 2-year study is because some of these immune system changes may be transient, and we would like to see which ones persist over 2 years. So some of the immune system changes we think will reverse as people recover from IM, but some of them may persist long term, and those are the ones we're interested in because those may be the signature that can be identified to see who'll go on to develop autoimmune disease. So the question we want to ask is very simple. What are the changes to the immune system as a result of mono? And we'll also look at people who have got a strep sore throat to see if they, as a control, to see if there's differences between the viral infectious mono and the streptococcal throat infection. Then we'd also like to get control subjects. So control subjects have to have no prior history of mono. And then we'll invite them to participate in a very similar follow-up over 2 years. And obviously, some of these people will have had EBV infection without mono, is what we call asymptomatic infection. And this is quite common, actually, not to get mono. Only about a third of people who get exposed to the virus in adults, as adults or adolescents, get mono. The others don't get a mono. And so we'll have 2 groups here. We'll have people that are EBV negative and people that are EBV positive from asymptomatic seroconversion. And the question we're going to ask is, what are the changes to the immune system as a result of asymptomatic infection or not having EBV? In other words, we'll have a control group that haven't been exposed to the virus, so we can compare what happens when you have asymptomatic seroconversion or symptomatic seroconversion with mononucleosis. Then once we finish those 2 parts, we'd like to bring people back into for the final part of the study, which is part of the part 2, where we will offer people the option of going on to a course of an antiviral therapy. So this is actually an old drug that's been around for decades. It's very safe. It's used to treat chickenpox. Varicella zoster is the other name for that virus, or herpes viruses. So it's been licensed to treat a related herpes virus. And we have some evidence that people with infectious mononucleosis respond to this drug. And we would like to then give people a 7-day course of an antiviral and then also study them on the same time points. And the idea is to see if this antiviral therapy reduces viral loads and affects the immune changes that occur as part of infectious mononucleosis. And this obviously will lead up to, this is a positive part. If we can show reduced viral shedding, then we have the data to actually justify a large multi-center study to develop this antiviral as actually a treatment for mononucleosis. And if we can develop it as a treatment and the drug gets licensed, then we will have a therapy so anybody in the future develops infectious mononucleosis can go on to an antiviral. So that's the real aim, is to create the evidence base, the data, to support a much larger study across the UK and possibly other countries. And the questions we want to ask is very simple. Does treating mono with an antiviral medication reduce viral loads? And does treating mono with an antiviral medication alter changes to the immune system due to Epstein-Barr virus? So we would value your input. This is a test, so we would like your feedback on the Barts mono study. Do you understand it? Does it make sense to you? Are there things that need to be explained in more detail? And so if you do have the time, please take a 3 to 4 minutes out of your day to complete the short survey by clicking on this link. And I'd like to thank you for your participation and support. It's much appreciated.